Welcome, Milda. I'm so happy to have you as our next presenter. And the topic of our lecture is model uncertainty in computational pathology. But before we dive into this, tell us a couple of words about yourself. Where you are, who you are, how your journey with the computational pathology started, and a little bit how you got involved in this research topic. Maybe it was just given to you as your PhD subject, but tell us a little bit about yourself.
Yeah, hi Alexandra. It's so nice that you invited me to participate in this event. I'm very, very excited about this. So I am in Sweden, in a town called Linköping, and I'm a fourth year PhD student, so I'm very close to being done with my PhD. And my path was a little bit, zigzaggy to get to this position. So
Uh-huh.
I studied financial mathematics in my bachelor, so I actually come from very different background.
Okay,
But
yes.
then through meeting different people and working in several different workplaces, I ended up being in Sweden because I'm not from Sweden. I'm actually from Lithuania, which is a small country in
Uh-huh.
Europe.
I'm from Poland.
And
We are
oh,
neighbors.
nice. Yeah, we are neighbors. Very nice. Yeah. So my path led me to meet Klaus Lundström, who's my supervisor, and he is very active in digital pathology research. And then we discussed possibility to do a PhD, and here I am doing a PhD. And my topic of PhD is explainability and uncertainty, specifically for digital pathology applications, so deep learning and digital pathology, which I think is very important and exciting fields to be.
Yes, and a very necessary. I probably already said this in other lectures today that it nobody argued with the results at the beginning, and everybody was so happy that it was outperforming the classical methods. But then people started asking, okay, can we okay, nice, can we use it for medical decisions in if we don't really know what those decisions are based on? So explainability is a big thing, definitely will be a big thing for regulators when we start approving those algorithms, those models as medical devices and aid for pathologists. But what is this uncertainty? Where does it fit in the explainability spectrum? What is it?
So that is a good question. And I think uncertainty, most people have quite intuitive feeling what it is because
Hmm.
like the weather predictions, they are uncertain, right? Like whatever app tells us what's going to be weather tomorrow, it's quite often not exactly what is happening the next day. And the reason is that it's the definition of uncertainty is that it's some prediction or some decision that based on incomplete information, so where we
Hmm.
don't know what's what's really going to happen, and we just make the decision based on some preliminary information and facts that we can gather and yeah, make the decision. And it affects medical doctors. So for example, a pathologist, they don't know if there is, for example, breast tumor metastasis in this lymph node section, but they have their means how to process the information that they have. So let's say the given slide, and then they can make the decision, is there a metastasis or not? But that decision contains uncertainty because they did not have all the information. If we
Hmm.
had always all the information, we would never make wrong decisions or wrong predictions or anything like that. And this
Hmm.
affects also the algorithms, because the algorithm it has some sort of, it was trained to do some task. It saw many examples how to do that task, but it doesn't really have all of the information. And that's why sometimes it's right and sometimes it's wrong. And it is very important for us to know when it's likely to be wrong, when its prediction is kind of more like a guess and not really based on a lot of information that it can process.
Hmm.
And this can happen a lot when you have test data that somehow is different from what it was trained on. Then it's much more likely that it would make that kind of uninformed prediction.
And we're going to have a talk about that. Christina is going to talk about
Okay.
the main shift, which is where the slides are different from what we trained on to what we predicted on. So stay tuned for that one as well.
Yeah.
But let's go back to this. Yes, intuitive concept, uncertainty, but so it's like obvious you are not really believing 100% the weather prediction. Can you allow, can you afford not believing the model, or I guess you can if you know what's the level of uncertainty. So how do you measure that?
Yeah, so that is, I think that's where the most effort in this field is kind of focused, because uncertainty, it's easy to understand intuitively, but it's actually very difficult to measure. And the next difficulty is like, okay, if we can measure it, when do we make this action and start not trusting the algorithm, or like deciding to override the prediction by the algorithm? And so far, I don't think anybody managed to have a good answer to that. So it's a lot of work. But our idea
Because if
is,
it's
yeah,
like, even if it's like very uncertain, it still can be correct in the prediction, right? So how do you reconcile that?
yeah, that is that usually ties well with the idea, how do we evaluate uncertainty to begin with?
Hmm. Yeah.
Because we have these different methods where we get some sort of uncertainty score out of them. And usually it goes between 0 and 1, and 1 indicates a lot of uncertainty and 0 indicates like no uncertainty. But how
Hmm.
do we say this specific method that gives uncertainty is really good and that one is really not so good? So one way, and I think that is the most common way how people look at it, is that they kind of look through of the application. So for example, in digital pathology, we could do like a triage. So let's say we
Hmm.
have whole slide images, or we have patients, like it doesn't matter. And we have like predictions for these patients, and we want to say, we would like to omit completely 20% of patients that are that don't have any disease, whatever disease we're trying to find. It can be cancer metastasis, it can be just cancer, it can be, yeah, there are so many diseases we can be looking for. And
Hmm.
then how they use uncertainty in those cases, then they say, okay, but then let's estimate first the uncertainty of each prediction. And the most uncertain predictions, let's keep them. Actually, they should be for the manual review, because those are like really where the algorithm is we shouldn't trust the algorithm. And like
Hmm.
the 50% of most certain, though, we can do that kind of automatic processing. So we don't need medical doctor to intervene. If the algorithm says there is no disease and uncertainty is very low, we say, okay, these we can omit. And then people calculate, they do these experiments, and then they calculate different metrics, like the performance metrics. Okay, if we
Which we
excluded
will
them.
have a talk about as well.
Okay, so I will not go too much in detail, but yeah, but the
Yeah,
idea is,
but totally touch on this. If this is relevant to your work and to uncertainty, go ahead, and then the knowledge is going to be
mhm,
filled by Francesco and
mhm.
Leander. They're going to be talking about that.
Okay. Yeah, so in this situation, I just can wrap up quickly that what we do, we try to use the uncertainty to make the decision better, right? So when algorithm is certain, we take the algorithm's decision. If algorithm is uncertain, we refer to the medical doctor for full manual review. And then we
Mhm.
can compare, okay, what was the performance on this experiment when we did it this way versus if we only did the algorithmic this
Okay.
detection. And okay, if you have a lot of pathologists who have free time and who would like to help you, you can also compare to the pathologist like decisions, but unfortunately
I
very
love how
often
you
that's not
frame it.
possible.
If you have a lot of pathologists who have free time and want to help you, how many of these have you met?
Yeah, not many, not many. So that's why often these experiments end up being, yeah, more comparing the algorithm alone versus algorithm with some cases referred to pathologists.
Hmm. So I have two follow-up questions to this. So the uncertainty calculation comes on top of whatever the model performance is in the first place, right? So let's say we have, let's take this example of lymph node metastasis, and we are segmenting the metastatic cells within the lymph node. So we have to have good performance in the first place, know that the segmentation is okay and reliable enough to even use this algorithm. And then on top of that, we check how certain in those predictions the model is. Is that correct?
Yeah, it's kind of
You are not sounding too convinced.
yeah, it's a bit complicated because in perfect world, if we had algorithms that would output probability, And by probability, what I mean is, if I say that there is 90% probability that there is metastasis in this slide, and if I collected like 100 slides, for each of them, the algorithm said it's 90% probability that there is metastasis in in each of the slides. So roughly, in ideal world, what would happen is that 90% of these slides, so 90 slides, would actually really contain the metastasis. But there would be 10 slides that would not contain the metastasis. So kind of the probability says like how likely is that something is happening there. And there is a lot of research showing that unfortunately in deep learning, the output of deep learning, even though people often say it's a probability, but it doesn't follow this proportion. And actually it's often is very overconfident. So it very often says like 99% probability, but in reality, it can be anywhere between like 40% of correct cases in those to like 100%. It's there is not really this clear connection between that number and what probability is that the prediction is correct. Okay. And then there is like a big research area where they call it a calibration. So they try different methods how to make this output score to correspond more to the probability. And it's very important because medical doctors are usually trained to think like probability is something that they have idea what it means. It can be very confusing if an algorithm outputs 0.99, which would, if you think about probabilities, it's definitely like there must be this disease or this metastasis is so high. But in deep learning, unfortunately, that does not mean that. So there is this area, and then they have different metrics where they kind of try to see, okay, does this score correspond to the frequency, how often the disease was present in, like if it's 0.9, it should be 90% of the cases present, and so forth.
So does this relate somehow to the prevalence of the disease, and like which metrics would you use there?
Yeah, so it's a bit.
So let me explain. So let's say if the prevalence is low, so in 100 cases you only have one diseased person, and you predict that all of them are healthy, nobody has disease, then you're 99% correct, but your algorithm is useless. So is there a connection with do you have to have a balanced data set? Does this play a role in this?
Yeah, definitely. The example that you gave is very good, and it's another big problem that we experience, right, in the medical data, that it can be that 1 person out of 100 has the certain disease or metastasis or something, and usually to evaluate these algorithms, people artificially make balanced data set. So kind of because the idea is if it works well on the balance, then when you have a big imbalance, it should still keep working well. So it still hopefully would detect that one missed or not missed, one person who has some disease or metastasis or something like that. But this is kind of very, So this is one part of kind of where you try to actually take the uncertainty and transform the prediction score to be that uncertainty. And that would be perfect, right? Because then we could just show to medical doctor, okay, this is the prediction, this is the probability that prediction is correct. And now you can make the decision. Like if probability is 0.3, maybe you really want to look through it a lot yourself to make sure, okay, was this really correct? If it's 0.99, you're like, yeah, it's probably quite good. And you can spend less time looking at it manually. So that would be the idea.
So here, a follow-up question for both let's say uncertainty and the translated probability. How do we define the threshold? Is it just the preference and confidence of the pathologist who is being aided by this tool, or can you do experiments? How do you define? So like what would be the uncertainty level that is acceptable and what is not acceptable anymore? And how do you determine this? Can you even do that?
Yeah, so
yes, that's what I'm doing my PhD about.
Very nice, yeah. It's kind of, in ideal world, you would probably, the pathology department would have to think about what is really important for them. Because if you put the threshold very high, it means, I mean, high that it has to be very certain for a pathologist to accept that as a trustworthy decision, then it's a lot of manual work. But you would really minimize the chance of missing anything. If you put it very low, which means like you accept quite like more uncertain predictions, then you reduce the manual work, so you save a lot of time for pathologists. But then you have to accept this risk that some people, like some diseases, might be missed. And that also depends on your algorithm. Like some algorithms, some of these AI systems, they tend to overpredict the kind of not like overpredict that there's no disease, while others tend to overpredict that there is a disease in a like this specific type of data or type of diagnosis that you're doing. And that's also very important information. I think it has to be a lot of discussion between the vendor or like the producer of the AI system and the pathologist to really understand what is the risk. And based on that, then you can decide the threshold. Maybe if it's like a screening of like breast cancer in population, the workload is so high that maybe you are accepting a bit less certain predictions just to manage the workload if you have like very short, like you're short on staff and things like that. But if it's something that it's a rare disease and it can be very deadly or like very important to detect and you do have enough staff, maybe then you would really want to choose very high thresholds to be only trusting the system when the prediction is really, really certain. And as we talked before, of course, like that certainty, you also would want to know how did they evaluate that probability or certainty measure. Does it really match your needs of your specific hospital and your specific application? So it's a very, very complex kind of framework that in the end you want to build if you really want to get the maximum benefit from this sort of system.
And I see this, so we are still in the narrow AI part of artificial intelligence, and it's going to be, like you say, one task, one algorithm with all the restrictions or all the intricacies of the intended use, of the acceptance of the users, of the workload. It's a complex way to get to make our life easier. But I guess with the shortage of pathologists and with the increasing workload, we don't really have a choice. So it's going to be a bumpy road.
No, yeah, definitely. And I think why it's worth taking this more complex way, because the easy way would be like, okay, there is this AI. The producer says it's amazing. We just trust them. We just deploy it in our clinic. We just don't evaluate anything and we just use it as it is. And it is easy. But I think the problem would arise if you start getting some systematic failures, like some type of patients were continuously misdiagnosed. And it can take very long time to detect, especially if you just throw the system with like automatic manner or something. Or there could be another problem that maybe it makes the life of pathologists actually much harder. Maybe it has so many false positives or false negatives that it
they
really
have to work
doesn't
twice as hard
contribute
to review it.
Yeah, and that's why I think it is important to have this uncertainty or like the probability measure of correctness that would help at least to some extent tune the system better to work it with a pathology department and pathologist.
So let's say this is part of an algorithm, this information. How do you incorporate it in the final output? If we're talking still about the segmentation model for detecting metastasis, usually you just have a mask or some kind of like way to highlight, maybe it's a tension map or some way to point to the pathologist, this is where it is it correct or not? Like, how would you incorporate uncertainty? Would it be a number? Would it be a different color? Or would it not be visible for the pathologist and below certain threshold, it would just not show it? What are the ways of incorporating this into what we now know as segmentation algorithms, let's say? Or you can tell me about other types of algorithms as well.
Yeah, I think you kind of listed most of the ways how people have thought to integrate it. Yeah. So the one way that I said was this omitting even, or marking the very uncertain predictions for manual review. So there you would even not provide the algorithm output, because you would not want to confuse the medical doctor. You would just say, okay, this is something that the algorithm is not able to process with the certainty that you want to have. And we talked how it's not trivial to decide that threshold, but once you decide the threshold, you could say, okay, this is too uncertain to just even show that prediction.
And I am a big fan of that. I am a big fan of like, if you don't know if that's what it is, then just don't show it. There are, I think, different school of thoughts. They're like, oh, I show it with the number, and then people can do whatever they want with it. But I mean, once this is shown, you're thinking about this region and considering it, which is already biasing you. So I like that. I like that you don't show stuff that you don't know what it actually is.
Yeah, I agree with you totally. And the next part is, if it's certain enough to show, then there are, of course, different ways how we could show. We could just show one number, which was supposed to indicate the probability of it being correct. And then you show a segmentation map, like all of it, all those predicted regions. Then you could actually be filtering out regions. So instead of showing, you could also show that one score, but also within the regions, you could filter out the prediction regions that are very uncertain. But maybe in that case, then of course you have to consider that something was removed. So maybe you should, or you could mark them in a different color, right? To indicate that this is something that's not so certain, but was predicted. So it's a lot of, I think this area is called human-computer interaction and this design of interfaces. So it's a lot of their work trying to figure out what is the best way to present this information to person. And as we talked, you don't want to bias person to make wrong decision. You want to help the person, and you also want to be as transparent as possible with showing your uncertainty as a heat map or as some sort of number or something. Like one of my colleagues, he did a solution where he was taking it was colon cancer, the kind of task to detect colon cancer or diagnose, and he was just showing the whole slide image where the doctor will be working, and then the kind of areas that are most likely to contain the cancer were kind of zoomed in, so they were larger, and the doctor could be just clicking a button and skipping between these risky areas and looking through each of them. But at the same time, at any moment, they could just push all the areas back into the whole slide image and look at the whole slide image as a whole, as normally they would do.
Okay. So
feedback was very positive from the pathologist, but of course you have to get used to working with a very different workflow.
I need to find an expert, and if you know an expert about human-computer interaction for digital pathology, this is definitely something I did not explore yet in any of my talks, so definitely a follow-up. And if you are listening to this broadcast and you want to listen about this, drop a comment that you want to hear about human-computer interactions. Okay, so let's talk about the applications, the research applications that you're dealing with. I assume the example that you gave about are you doing the metastasis or are you doing some other stuff?
Yeah, I'm working with breast cancer metastasis. That's why my many examples were from that. And I'm looking at a few different applications for uncertainty, how they could benefit basically the whole system or framework. So easiest one is to detect wrong predictions. I have its false positive or false negatives. And then I'm looking at, can we detect that on the slide level? Can we detect it on this region? Like if you do segmentation and these different segmented regions, can we say that this region is correct and correctly predicted while this region is incorrectly predicted? And all of this, the idea is that for any of these steps, in practice, you wouldn't have the ground truth label. You wouldn't know, but you would have some sort of system that uses uncertainty and can tell you this information that this is most likely incorrectly predicted. And then as a pathologist, you can look at it and be like, yeah, it's incorrect. It's obvious. Or maybe you would want to override that decision. Maybe it is correct in the end. And hopefully in the future, we would have this feedback loop that the pathologist could give feedback to the system that this was actually correct. And that could be
Mhm.
used to retune many things to make sure that the next time the kind of suggestion would be much better. Yeah.
Mhm.
So that is one application. The other application is this triage that I also mentioned. That is like the idea that to reduce the workload, that we could do automatic diagnosis or automatic rejection. Let's say if it's like a normal case, there is no disease that we're looking for, or like no metastasis that we're looking for, and like certain percentage of the cases. And it's really useful where it's a very big workload coming in. So all of these screening,
Mhm.
screenings that are happening in the society. And there is quite a lot of effort, even now validating actually algorithms, how well they would perform in this screening setup, that it's many people with some biopsies taken or something, and that you really want to eliminate or like reduce the workload for medical doctors. And
Mhm.
then you would skip some percentage of very certain negative kind of cases.
Okay.
Yeah, so I think those are, to be honest, currently two main approaches, or like two main
Mhm.
applications where we could use uncertainty.
Mhm. Okay, and then you can basically apply it across medicine. I mean, there are plenty of screening tests that require a lot of effort. Okay, fantastic. We have a couple of minutes left. So,
Mhm.
if you have any, did you already publish your work, or is it still waiting to be published? If you have, then we can link all those papers. I'm gonna get these publications from you. Did you publish or not yet?
Yeah, I have
You have?
actually two papers published on uncertainty topic. So
Mhm.
I can definitely send you the links, and it'd be very nice if you could link.
Yes. In the recording, we're gonna include these. Definitely.
Yeah.
Okay. Thank you
Mhm.
so much for giving us this talk. This was really fascinating. I am very fascinated with with the explainability subject. It's going to be part of all the algorithms, and it's funny to me. Well, it's probably not funny because, like I said, you don't argue with results when they're fantastic. Only later you think, okay, are they really that fantastic, and how we can quantify how fantastic they are. And I will be asking Francesco and Leander about where this uncertainty fits into all the model performance metrics. Thank you so much, Milda, for joining us. And everyone who is listening to this, if you can, listen to the next talk as well.
Okay.
Thank
Thank you
you.
so much, Alexander, for organizing this. Yeah.
Bye.
Bye-bye.